Next up, we have Dr. Rindlisbacher and myself. We're going to present some sports medicine cases.
Yeah. So how are the slides advanced?
If you want, I can do it if you want. It's just the
I
arrow.
can push the button. We're going to be detectives today. Props are great. I'm not going to do the accent. I'll either embarrass myself or hurt myself. So this is concussion proof. So not an uncommon story. You're going to hear this case probably at some point. 17-year-old, this happens to be a male hockey player, presents with acute worsening of a problem that kind of happened the season before. So he gives a vague history of medial more than lateral knee pain, and he feels it happened with a certain hit or twist mechanism the year before. So this year, he presents a few days after a subsequent injury. So about 1 week prior, he's playing hockey, and he says his knee felt funny all of a sudden for not obvious reasons, but he thought there was another sort of minor injury. But he kept playing, and after the game, his knee really swelled up a lot, and so he presents to the office. And my examination was such that he had a large effusion, but it really wasn't hot. The joint wasn't red, but it was certainly a decent size effusion. In terms of joint line tenderness, it's important, obviously, to be poking around at all the spots. Medial, not lateral. His range was actually surprisingly pretty full, given the effusion, and he had pain at both end extension and flexion. His McMurray's test was positive. I didn't do a Thessaly's. I'm not convinced it's useful personally, but there was a potential click and certainly some pain with McMurray's, and all of his ligament tests were normal. So put out the most obvious thing. Somebody shout out something. Meniscus, right? Meniscus tear. And so you can get sort of blinded, I think, with these. I know I've almost caught myself sometimes. This is a meniscus tear. He needs an MRI. I'm going to call in favors and get this quick because he's a young player and he's an elite athlete, and I'm just going to get that MRI. And one of the takeaways I want you to remember today is do an X-ray, because even the things that are seem soft tissue, you can find things on X-rays. So did an X-ray, and given this view, and maybe a mediocre radiologist on a bad day, or one of us on a bad day, might miss this on this view. So one of the other takeaways is do lots of views when you've got stuff. We'll come back to this view in a moment. But if you see something there, great. If you don't, that's okay. The lateral view, again, you might miss it if you're not looking carefully, if you're being quick and sloppy, but there is something there that we'll come back to. So I'm trying to give you little tidbits of clues. Okay, so this is why I do obliques on young players, and that is a couple of things. We see this fragment here, which is not normal. It's not a fibella. Which would be the posterior aspect of the knee. And we see something kind of funny going on here, right? If you're following your femoral condyles around, looks a little strange. So also in this case, if you were really on the ball, you would have ordered a tunnel view. And in the tunnel view, it's really hard to miss. Because this knee on the right, you look at that medial femoral condyle, one of these things is not like the other. So this is called osteochondritis dissecans. It's not that rare. And the medial femoral condyle, I think, makes up 75% of all possible osteochondritis dissecans cases. That includes elbows and ankles and some of the other spots that can happen. And he's basically, you can see, you get a sense that there might be a fragment there. We already saw this little fragment over here. You may have seen that on the first image too, if you're being careful. And so the CT really, allows that three-dimensional characterization of the fragment. And so you see in the transverse, coronal, and sagittal that he's got a few loose bodies that need to be dealt with. Another set of views here. The most obvious one is that lateral recess. He's got a big chunk right over here. So I sent him to a surgeon. I'll get into that in a moment. But basically, to kind of wrap up their stages of osteochondritis dissecans, you've got this sort of softening, if you will, is all you would see if you were having to take stage 1. You might see a little softening of the articular cartilage. Really not much happening from the outside. And in stage 2, there's maybe this fibrous attachment going on between the fragment, but it's quite a stable. The first 2 stages are what we call stable lesions. And then they become unstable as they progress. So this is the evolution. And now you might see synovial fluid tracking behind part of the fragment, but it's really still partially attached by some of the articular cartilage. And then you get an actual loose body, sometimes called the joint mouse. And this can basically end up anywhere. If they end up in the posterior, in the popliteal fossa, they can kind of just sit there doing nothing. But this kid really started to get an effusion because he was getting trapping, right? And he's pinching his fragment. So next week, 2 weeks, he's getting scoped. And I believe the surgeon is going to try to take that unstable lesion and pin it down. But these are the quick takeaways here that I thought should be mentioned. And I should have put actually a tunnel view there too for this particular case. But yeah, these athletes, we deal with them all the time and kind of get used to they're tough and they're going to gut through stuff. But it kind of surprises me every once in a while how desperate, I'm going to make that game. I'm going to play that season. It's my draft year. All those kind of things that come up where they will play through things that you don't expect. So that's a little take home for me. All right. So we're going to some other cases, even better cases.
Thank you very much, Tim. Great to see the diagnosis come down the pipeline.
Twisted right.
Okay. This is case number 2. We actually have a video for this one. And I'll play it a couple times if it works. It's not working, so that's okay. I'll get a backup. How do I control and click?
And we'll have some time after for questions.
So you're just going to play it a couple times. It looks fairly innocuous in terms of stepping. Obviously not his reaction to it. It does not look innocuous, but his left knee as he goes to plant, steps on the ball and then down on the foot. So this would have, if you look at it again, watch how his foot touches the ball and then comes to the ground. Ball, ground. Okay. So that was the injury, and this is how he presents in the medical room afterwards. Okay. So that was his left knee. Okay. And who would like to describe what they see? Okay. So first off, can You see the predator, okay. So first off, in the middle image, do you see any difference from one side versus the other? Where do you see the fullness? Yeah. So you can everybody see what Mark's talking about here? Okay. And then when we take a look at the outside of the knee, this is the right, yeah, right accommodating with right. You can make out the definitions and specifically the concavities of the normal anatomy. So you can see the concavity of the anterolateral joint where we're talking about landmarking for injections. We can see the fibular head. We can kind of make out a joint line based on where the lateral musculature comes in. And then when we take a look on the left lateral knee, it kind of looks fuller, flatter. There's less concavity. And that's really what we're looking for on clinical examination. Now, this is a different area than we're typically used to looking at. He didn't actually have, he had a very minimal effusion, joint effusion. It was, actually, no, he didn't have a joint effusion at all. This was all superficial and lateral. So, couple things. What's concerning when an athlete is having difficulty weight bearing in the outside and back of their knee? Is there any injury that comes to mind? Posterolateral corner. And so I'm going to show you the MRI here actually afterwards. So I'm going to show you this is something called a dial test, which you can do with the patient lying prone. And you have their knees flexed and you rotate the feet externally, which externally rotates the tibia, the knee, and you'll see an increased rotation. That's because of instability. Okay. This is an anatomy diagram of the important ligamentous structures and minus the biceps femoris tendon, which essentially comes down over top onto the fibula. And so we're looking at here at the lateral collateral ligament or the fibular collateral ligament, the popliteal fibular ligament, and then the biceps femoris tendon. So we're going to go back here. And when we take a look at this image, you can obviously make out that there's quite a bit of edema in the lateral aspect of the joint. But these are from a ligamentous perspective, this almost you can see like a U-like structure or an M-like structure here. That M is supposed to be sitting over here. So it's completely avulsed, and that's why he has instability. Now, sometimes you'll get a posterolateral corner strain, and that'll be an attack, and they won't have any instability, and you can essentially conservatively treat them. When you have one of these, however, it's kind of similar to an ACL in terms of the importance of the stability it provides for rotational movements. So this is the MRI findings. Oh, where is it here? So they avulsed the conjoined tendon. The conjoined tendon is the combined biceps femoris tendon that kind of connects in with the fibular collateral, the lateral collateral ligament. Okay, and then the popliteal fibular ligament was also avulsed. And then because it's as his foot came down, there's an extension. So you think if the lateral side is giving way, you also can then compress the medial side. That's why there's a medial femoral condyle contusion as well. So he ended up having surgery. This is like 5 to 6 months to return to play. So it's a fairly significant injury. That's why it's important to note. And once again, there's no swelling in terms of an effusion from the joint necessarily with these, unless they have an associated meniscal or other ligamentous injury. And that's, you got to kind of note that swelling on the outside. That's kind of the important feature there. Any questions about that one? Okay. This next case, another soccer player, same thing, was actually just in the process of warming up and felt something give way in his knee and then hopped off and comes in, and this is how you see him. What do you note on examination? What's that, sorry?
We can see like
Sure. This actually is superficial. This is kind of a red herring. He had a superficial turf burn. That's not part of the injury. Actually, in fact, on the examination, the only positive finding from a palpation perspective was tenderness above that. What's that? So his patella is more prominent, but why is it more prominent? Is he resting comfortably in the bed? He's in more flexion. In fact, he won't let you get his leg straighter than that. He's not in a significant amount of pain. So if you're talking to him, you can kind of straighten it out, but it won't go past, you won't get closer to 20 degrees from being straight. The joint is blocked. No joint effusion. This is the other important thing here. So we're used to, talking about like when you're examining knees, you want to take a look for that joint infusion for essentially the intra-articular injury. And we just had 2 cases of essentially a significant knee injury where there's no joint effusion. So what do you think might be happening here? Yeah. Why might a bucket handle, though, not have a joint effusion? Why is there no swelling in the joint? What's that?
It's an old bucket handle.
Sure, it could be an old bucket handle.
Or a new one.
So really only the outer 20% is significantly vascular. So if you have a bucket handle at 50% of the portion of the meniscus, you can have a complete lack of an effusion. And in fact, very minimal pain. He had a little bit of anterior medial tenderness, but like I really had to push on it. So on the MRI, what you're taking a look at here, so on the coronal to start, okay, you can see the hyaline cartilage on either side here. And you can see then there is a circular bit that's not supposed to be there. That is the bucket handle. On the image on the, I don't know how well you can see it because I'm kind of got a glare here. But on the sagittal image here, this is the bucket handle here sitting in the middle of the joint. Okay, there's PCL. Okay. And then on the axial, you can see this portion here, which is the bucket handle portion of the meniscus. So he actually had 50% of the meniscus removed as a result of this injury. Now, to go back to one of Kim's points is that given how innocuous the injury was, he likely had a partial tear in his meniscus to start, and then that whatever movement he did, he was kind of just essentially stepping down from running. The rest of the meniscus went. Okay. This is case number 4. Okay. So I was asked to assess this player after having played a full 90-minute match. It got on for 4 weeks. Okay. And kind of got like pain over like typical classic shin splint area, distal third, medial tibia. The only difference is where he was maximally tender is there was a slight bump that you could actually palpate. Okay, can anybody see anything on the X-ray? So the X-ray was read as normal. Okay, and can I use your pipe for a second? Absolutely. So we're going to take a look at this area here. Okay, you can't see anything on the lateral. This area here, it doesn't really come out too well, but on the there's a lucency that comes through the cortex. It doesn't it breaks the cortex line superiorly, but not inferiorly. And there's not supposed to be a bump, so there's no muscular attachment there. So that's not supposed to be there. So we proceeded with an MRI, which showed a periosteal hematoma. So on the easiest one to see it is actually on the, first off, we'll just go to correspond with the X-ray. On the coronal image, you can see edema that corresponds with where that bump was, okay? And then on the medial aspect, see almost like it looks like a kind of a rounded triangle. That should be black through here. This is the periosteal hematoma, and you can see covers about 50% of the width of the bone marrow. So this athlete actually had a stress fracture about 4 weeks till he was non-tender, and he'll be about 8 weeks before returning to play with vitamin D. But once again, this is about trusting your clinical examination. You know, with a medial tibial stress syndrome or shin splints, don't always have them bilaterally, but you shouldn't really have any kind of bony bump in that area. Okay. Case number 5. So once again, we've got a goalie blocking a shot with the left wrist. Okay. What do you see? Jeez.
Look at me.
Yeah.
Oh, swelling on the left one.
Yeah. Can everybody see where the swelling is? So the snuff box area on the right, okay, you can see here you have a flexor carpi realis here, and then you have your extensor tendons. There's kind of a concavity here. It's almost completely absent. It's almost convex on the left, okay? So here you have a joint effusion, okay? So we take the x-rays. Does anybody see anything abnormal on the x-rays? I'm just going to give you one view here. So the x-rays were read as normal, and in fact, they look entirely normal. And 3 weeks later, 13 days later, effusion's starting to go down, still present, starting to go down. He's feeling a lot better. He wants to go back to play. Still got 10-degree loss of range of motion, flexion, extension. You're gonna let him go back? What's the concern here if you let him go back?
Mr. Worsen fracture.
So a scaphoid fracture. Well, what happens if you miss the scaphoid fracture?
High risk for AVM.
Yeah. And then what happens?
Because they have a messed up bone. They need surgery.
Yeah, they end up getting like very early arthritis, limited range of motion, and this is a 20-year-old athlete. So we proceeded with an MRI, and you can actually see the this is about 3 weeks post. You can see the amount of bony edema, and if you go back and you look at the X-rays, there's like literally no sign. Okay, this is why it's so important. The most important thing with these wrist ones is that if you're seeing them initially, is that you make sure that they have follow-up arranged so that you can reassess them. Because 9 times out of 10, it'll end up being like a contusion, and they'll be non-tender by the time you get to see them in 3 weeks. But in this situation, he was still point tender when you palpated the scaphoid. A couple things with the scaphoid. So you can press on the snuff box, okay? But then you can also ask them to ulnarly deviate, okay? And when you do that, you can actually increase the amount of the bone you can palpate. So if you press the snuff box and they have a waist fracture or proximal third fracture, they may not be tender. So you can get them to ulnarly deviate and then press. And then the second thing is you should also be doing an anterior posterior plane palpation of the scaphoid.
What was the mechanism of that?
Block shot. So at this level, so it's not unusual. We've had I don't know how many, 4 or 5 scaphoid fractures from block shots. They're striking the ball at like a tremendous force at this point. UCL tears, elbow from block shots. This is soccer. Yeah.
Like a block shot.
Block shot and then hand gets, yeah.
Quick question.
Yeah.
Let's say this is in the community. I can't pull a favor and get MRIs that soon.
Wonderful question.
What do I do? Like a bone scan? Would that suffice? Or would that...
You could do a bone scan. So the other thing you can do is you can repeat the X-ray. So repeat the X-ray, and you may very well start to see either a line of healing or, especially with scaphoid views. And if you're still not, then you would essentially, you can either refer to directly to plastics or a hand specialist. So we'll often recommend, like if you're in the community, like for example, Toronto, you can call Toronto Western Hospital and ask to speak with the hand specialist on hand. They can arrange a closer follow-up. And then if you're out in the community, then the other option would be to refer to a hospital, and they can refer to a plastics clinic from there.